Welcome to the Crown Council Mentor of the Month. It's Steve Anderson, and I am delighted to introduce our Mentor of the Month guest, Katie Poulsen. And Katie, in addition to being a registered dental hygienist, also has a master's in professional communication, which, Katie, I have to admit, is more than what I have. So I am fascinated for our conversation today. She has also been a clinical adjunct faculty member at Weber State University's Dental Hygiene Department, is also a past president of the Utah Dental Hygienists Association. Congratulations. She is a practicing hygienist, also a practicing marketing, a practice marketing expert for the practice she works with Dr. Jonathan Campbell, also in Salt Lake City. So here's the topic of conversation today, and this is what really piqued my interest. Not only, Katie, are you doing this every day, but you have done some unusual research that will be the topic of our conversation today. And the research that you have done is entitled Dentist, Dental Hygienist Conflict through the lens of communication accommodation theory. Now, there's a lot of big words in there you're going to have to explain to me. But we're going to talk about two things I understand today. One is how the dentist hygienist communication and challenges with communication, how that impacts the culture in the practice. And number two, how it impacts patient care. So with that, welcome and thanks for being our Mentor of the Month.
Thank you for letting me talk about communication. It's my favorite topic.
Perfect. All right, so give us a little background on the research, how you got into this, what led to it for starters.
Yeah, so I'm a daughter of a dentist, and I grew up in that atmosphere. And my brother was as a dentist. He started with our practice 20 years ago. And when I started going to dental hygiene school and I went to my first national meeting, hygiene meeting, I started hearing all of this talk about conflict with dentists. And I was thinking, people don't like their dentist? This is so weird to me because I love my dentist. They're my family, right?
Right.
And so I was so confused and perplexed by that concept. And then I became the president of the Utah Dental Hygiene Association. And I just saw more and more that on a micro level in practices, there was this conflict that was happening on a macro level as well with the associations. And it kind of really troubled me. So when I was in school, I had this class and we were talking about workplace communication conflict. And I was like, that is what I'm going to study, because it's apparent, not necessarily in my practice, but with a lot of people that I've talked to. And so that's kind of the brainchild for the start of my research that I did.
Cool. Definition of terms. Tell us about communication accommodation theory.
Yeah. So as you can imagine, there's not a lot of research in communication in dentistry. So I had to use a lot of research from doctors and nurses and just the healthcare setting. And so a lot of the research that already exists has this theory of communication accommodation theory, which is essentially we as humans accommodate or change our communication by the way that we talk, by who we're talking to. So with leader member exchange, there's leaders that have followers in their in-group, and then there are followers in their out-group. And you change the way you speak to someone based off of if they're in your in-group or their out-group, if that makes sense.
I mean, so there might be a difference in how I communicate with my children versus...
Yes, a family is a great example of that. Okay. Yeah, definitely. Yes, you as the leader of your family communicate differently than with people in your out-group. Yeah.
Got it. Okay, that easy. So very sophisticated term for, I think we all get it. We change the way we communicate based on the audience, right?
Yep.
Okay. All right, so here was research question number one, as I understand it, is how do dentists, dental hygienists describe the nature of communication conflict in their practices? So tell us about that. What did you find in the research?
So my goal with this question was to really just understand if maybe it was just me that thought there was conflict. Okay. Do people think that there's conflict? and then also what do they do about it? What does it look like in their practice, and how do they fix it?
Okay.
And 4 themes just emerged from the research. It was essentially is everyone that I interviewed said there was conflict, which is obvious. I mean, there's conflict in every human relationship that you have.
Right.
So, and then expectations were the main theme that everybody kind of came up with that was the reason for the conflict that they had. Specifically, there was this one particular dentist who was like, 99% of the conflict I have in my office is because of unmet expectations. And then he followed that up with, I probably don't give my expectations that I want, but that's the reason for the conflict. And the other was, the other themes that emerged were conflict avoidance, which is just kind of, that's how they dealt with it. And I think the reason being is there was a couple scenarios where they gave me, there's always high intensity when they're trying to have conflict. Somebody's always crying, they come to someone to try to combat behavior or whatever, and then it turns into crying. And nobody wants to make somebody cry. I mean, nobody, I don't think, loves conflict in the process, but so they kind of punt that to whoever in the practice will deal with that, right? So that they can do dentistry.
All right.
And on the other hand, the hygienists really felt like, and the expectation problem was a problem as well, but in the sense that they know that the dentist is mad that the expectations aren't being met, but they don't know what expectations they're supposed to be meeting. So there's definitely a communication gap that is happening between expectations there. And it's just in a personal experience with just my own job as a hygienist. In the state of Utah, we can't diagnose periodontal disease, but we can treat it. So we're treating periodontal disease, and we talk to the patient about what they have and the problem, and then the dentist comes in and says no, or vice versa. You don't treat perio when they come in and they say they want you to do that, right? And so this role ambiguity, this role overlap is kind of, I think, based off of the research with like doctors and nurses, and it happens with dentists and hygienists, it's part of the reason for the conflict. So that was a really interesting theme that emerged.
All right. Can we talk about expectations for a minute?
Yes. Yeah.
All right. Because this is big, not surprising.
Yeah.
What is interesting about it, though, is how prevalent you found it to be.
Yes.
So it sounds like it was just about everybody.
On both sides.
On both sides.
Yep.
Okay. So let's talk about expectations for just a moment in terms of what are the different areas of unmet expectations for the doctor.
Yeah. So as far as the depth to the expectations that were unmet, that we didn't get too far into them. They expressed mainly with, if they were to present an idea, take for instance, having you guys TOPS come in and take over, or to implementing a new software program, right? And everyone says that they're on board, and then it fizzles out, right? Or just, that was the main theme that was brought up just within the research. So
okay, so let's dig into that just a little bit. So let's say it is a new hygiene protocol, anything new you're implementing in the office. So the assumption on the dentist part is that everybody's going to grasp it, promote it, move with it, and implement it. Whereas the team member or the hygienist might perceive that they have some say in the decision, or whether they like it or don't like it or whatever. So then dentist responsibility, I'm gonna get granular here.
Yes, I think a lot of the time you have to, it's generalization as well with this, but.
Right. Yeah. So the dentist responsibility here is, if there is an expectation of implementation of something new, then that expectation needs to be clearly delineated on what that looks like.
Right.
Meaning,
exactly.
Here's what we're going to do. Here's why we're going to do it. Here's the timeline, and here's what I expect from everybody as we move through that.
Yes. And not why the patient's in the chair.
Okay, so it's
conversations need to happen way before. Yeah. Okay. Yeah.
So would you say in this area, in terms of expectations, that it would, based on what you found, it would be very difficult for a dentist to over communicate expectations?
No, no, you cannot over, no, you can over communicate them. And it would be really interesting to see what the research would look like if we were to do scenarios where we would teach someone how to, in your instance, teach someone how to communicate these expectations, and then what that would do to the conflict in the practice or conflict resolution. Because it's a lot easier to go back to someone once you've already had the expectation set, right? And say, remember how we talked about that? And now now it's open for everyone to interpret, right? And there's no walls flying up and you didn't tell me this, you know what I mean? So I think it's great.
One of the interesting things, Katie, in this that we find often, especially as it has to do with expectations of new things, changes or whatever, is if you're not careful, a dentist will go to the team and say, I'm thinking about doing whatever. What
Mm-hmm.
do you all think?
Yes.
And that gets interpreted by a hygienist or other team members as they get a vote and it's a democracy.
Mm-hmm.
Versus if it were clearly communicated, would be, I am looking at make a decision in this area. I'd like everybody's input. And once
Yes.
I process all that, I'm going to come
Mm-hmm.
back with the
Right.
decision
Yeah.
and look forward to everybody jumping on board, depending on, no matter
Yeah.
which direction we decide to
Yeah.
go, all in how it's communicated.
Yeah. And the other flip side to that is when I think a lot of times in the practices they don't give they don't give the input, so they're used to just the staff's not used to giving the input, or they don't think it's valued, right? And so that could be the reason why the expectation is not being met. Sure, we're going to implement this thing. I think there's a problem with it. We'll just pretend like we're going to do it and then it'll fizzle out, because maybe there's something that the staff can see that maybe the dentist can't, of why it wouldn't work, right?
Correct.
But when you're not asking input, it's hard to, they are not going to give it forthcoming. So
Okay, so I'm gonna line out here, over communicate expectations.
yes.
And then on the flip side of that is for the dentists, and we'll get to the hygienist in just a minute. For the dentist is when you get input, use reflective listening so that your team knows they have been heard.
Yes, that
Okay?
is huge.
Now, let's take it over to the hygienist side.
Yeah.
Okay, turnabout's fair play.
Yep. Yep.
So there is an expectation. Let's talk about this role overlap in
Yep.
diagnosis. So when the conversation that a hygienist has had gets contradicted by a dentist, right? That can happen.
Yep, it does.
Then there is an opportunity to get coordinated and come up with a better communication system so that there's consistency. Right?
Yes. Mm-hmm.
Okay. And you've alluded to this, there's a lot of things that we teach at Total Patient Service in this area so that patient care is not impacted. But short of that, you're a hygienist. Let's talk about what a hygienist can do in a non-threatening professional way to communicate to the dentist when the patient's not around of what the hygienist's expectations are in terms of in treatment room communication when a patient is present.
Yeah. I view my job as a hygienist as the resident educator in the practice.
Ooh, that's so good.
That is what I do.
Okay.
I love the preventative side of dentistry. Because I have so many dentists in my family, I often get asked the question, why didn't you go to dental school? And I say I'm the smart one in the family, but really it's because I love educating people. And that is a large part of what I do every day. And it's hard to educate if I am not on the same understanding as the dentist. And so my brother, who I work for now, we've taken the opportunity to say, okay, when we get into this scenario, what does it look like? What would you recommend? And then we kind of go from there. And so not that I'm diagnosing, I use very broad language, but I kind of prep the patient and talk to them about what it looks like. And take, for instance, a crown. I talk to them, this looks like something Dr. Campbell would place a crown on. And I show a video on a crown, and I do all this. So I just tee it up. So when he walks in the door, I can introduce the patient. We talked about a crown. They're ready to move forward. What do you think? And then all he has to say is yes. And then that's it. And
Right.
then the patient, and that's all. And it's the same thing with periodontal disease. You know, there's a lot of gray area in diagnosing and treating periodontal disease. It's so hard to know. Everybody,
Right.
and teaching dental hygiene, it's really hard to say, oh, well, and this is what the insurance says. It's so hard. And so I think it's imperative that everybody is on the same page. You know, when I see a 4 mm pocket with calculus in it and bleeding, I know what to do. And I know that when the doctor comes in, he's going to back me up on this, you know, but those conversations can't happen over the patient's mouth. You know, they have to happen way before.
So two things, Katie, that I heard was, one, clinically, the two of you are on the same page. I mean, philosophy of care is clearly understood on your side and the doctor's side. You're in lockstep there. Number two is you over communicate in the treatment room. So it is never a secret.
It's huge.
It's never a secret to Dr. Campbell what you have talked about with the patient. You re-communicate that, so he's never blindsided by something that you've talked about that he's not.
Yeah. And there's the occasional, patient that, oh, actually I have this tooth hurts. And sometimes they don't want to tell me, but,
Right.
yeah.
But again, so I mean, those are common sense things, do not always happen.
No, if there's one thing I've learned, communication is not automatic. It's learned. It's not something that you're born with. It's vital that you learn how to do it. And so, yeah, it's definitely learned.
Okay, let's talk about, before we move on, I want to talk about the avoidance behaviors in high intensity situations where there is emotion.
Yeah. So a lot of
conflict.
Okay. Yeah, like I said, I don't think anybody likes to be in a scenario where there is high emotion and there's like emotionally charged feelings, especially with people that you work with. But the dentists that were interviewed stated that this was the reason, this is how they kind of dealt with conflict, was just avoiding it, because they were highly charged areas.
Right.
You know, they're coming in and they're making people kind of sad or mad, right? And then they cry and then they avoid that.
Right. And so then as a result of that, it gets worse.
Oh, 100%. Yeah.
All right. So as the researcher and as a hygienist, what is your recommendation?
So in my research, I suggested continued research to do conflict resolution.
Okay.
Yeah. Actually, one of the doctors that I interviewed said, you know what, so if somebody could just come mediate for me all the time.
That's an avoidance behavior, Katie.
I would just hire a mediator. And I think that it's conflict resolution, if you could teach that to staff before the conflict happens.
And to the dentist.
Yes, to all. Yes.
Everyone.
Team conflict resolution ahead of time before the conflict happens, and know what to do would be helpful. The other thing that was brought up was a dentist did a quarterly evaluation. He didn't follow through with it very much, but I've seen it happen.
Okay.
And work really well. Is to have that quarterly evaluations done, so that you catch the small things when they're happening, you know, as opposed to having them build and build and build until, you know, eventually everything that they do bothers you. You know.
Right. So there's your recommendation here. There's some skill building here in terms of verbal skills on how to do conflict resolution, how to give feedback that is not emotionally charged. In other words, there are learned skills here in order to manage conflict or potential conflict.
Yeah.
Does not come naturally.
No, and it's not easy. It's a lot easier to say it than do it, right? I mean, it's changing people's personalities and emotions, and it takes time, but as a leader of a practice, I think it's important.
Okay, we're going to move on to research question number 2, which I found this fascinating. This is really the next step of this. So Research question number 2 is, how do dentists and dental hygienists use communication accommodation tactics to respond to conflicts at work? All right, so this goes to your communication accommodation theory. So what's really going on? So you talk to us about the in group and the out group. I found this fascinating. So tell us what it is.
Yeah. So again, the in group was people that you speak with, you communicate really well with, and then an out group would be somebody that maybe you don't communicate greatly with.
All right.
And the research that I had studied prior to my research, so with nurses and doctors, and then also with nurse anesthetists and anesthesiologists, they found that the other person was in the out group. So the doctor had the nurse in the out group, and the nurse had the doctor in the out group. So I thought when I did my research that that's the way it would be probably with dentists and dental hygienists, that they would kind of maybe be in the in group, maybe with the office manager, both of them, and then the other one would be in the out group if there was conflict in the practice. Or I was hoping that I would find, oh no, we don't have an out group. Everyone's in the in group, right? Which would be great. But I found that the people that I interviewed said that the dentist, the hygienist felt like the dentists were in the out group, and the dentists found that they were in the out group. So the dentists outgrouped themselves, which was really fascinating to me. I wasn't expecting them to be on their own. And so
their own admission.
Yes.
Yeah. So they're saying I'm on the outside
of my practice.
With every team member?
Yeah.
Wow.
Yeah.
And so that's a self-perception.
Right. And I obviously defined the definition of in and out group. I think some of them that I interviewed at some point had an in group, maybe with an office manager or the lead assistant or something. But as conflict happens, trustworthiness, they can mention like, they lost trust in them or something. And then now they just kind of feel like they're out on their own, and they're outgrouped. And gosh, I was shocked by this, but also like I look at Dental Town or all of those, they are together. They don't have a lot of people to talk to, and so they talk to one another, which I get, but they're kind of leaving their staff out of the mix. So I found that really interesting.
Okay, so if someone self-identifies as being out in the out group, mm-hmm. What are the communication? What kind of communication then connects with that? I assume they under communicate.
Yes. Yeah,
they don't express expectations. What else?
They have guarded language. They change their language so that they like the dentist that I studied said that they kind of chose to be in the out group. They established boundaries. They had their role, and they changed kind of their language, just like as you would with somebody not in group. And I think what happens now when you do that is it makes it so that when people do need to come to you as the leader, when they have a problem, they don't know how to talk to you because you're in the out group, not the in group. And so there's this natural wall that happens just from not being in the same communication group.
Okay, so what's the prescription here? Obviously, boundaries are appropriate. Every relationship has boundaries.
Yeah.
Communicating with the right language, all of those things. I think we could argue that all of those things are important. It's mm-hmm. now what's appropriate for the relationship. So how do I, if I'm a dentist, how do I perceive myself as more in the in group mm-hmm. and still have the appropriate boundaries so we can communicate better?
I understand the hardship of owning a practice is very, very, it's difficult. I've seen it in my own life.
You grew up with
my dad do it.
You lived.
I listened to him come home and be frustrated with staff members.
Right.
And so and there's a lot of it that this rest of the staff, they just don't get it. They don't understand. And so I understand the desire and sometimes to just, all I want to do is dentistry. That's what I went to school for. And so everything that's not dentistry, I'm going to punt to my office manager or treatment coordinator or whoever else. But really, when it comes down to the leadership responsibility of um, helping your team and the relationships with your coworkers, it's not something that you can pawn off to the office manager. It really has to come down to you. The manager needs to manage, not lead. And
You can't hire a moderator for every situation.
right, a leading and managing are not the same thing. Sometimes they get confused as that they are, but they're not. And I think a lot of the stuff that they hand over to a manager is perfect, but trying to get rid of the relationship aspect with your employees, they're your employees, so you need to have the relationship with them and try to include them in your group, in your way of communication. It's dentistry is tricky because you are the provider and the business owner. Correct. As opposed to all other healthcare professions. And so there is a natural space, a natural disconnect that happens. And it's going to take a lot of forethought and a lot of thinking to try to bridge that disconnect. I think some dentists do it fantastic. I mean, some offices are just phenomenal, but.
Okay, if I were, based on your research here, if I were a dentist and I said to you, Katie, I get the research and I probably am just like everybody else you research. I'm a horrible communicator. I don't like dealing with emotion. I don't like conflict. I don't like any of this stuff. Boil it down to me. What would you recommend that I do? Simple, keep it simple. What would you recommend I do as a first step? I can't get away from this because that's the biggest thing that comes out of your research is avoidance.
Right.
The more you avoid it, the worse it gets. Okay, so what's my first step?
I think morning team huddles.
Imagine that.
Yes. Okay. Staff meetings regularly, team building opportunities outside of the office. As much as sometimes that doesn't sound very much fun, it really is important to gather your group when you're not in the chaos of work. And then I think quarterly interviews are really important. One-on-one, evaluate, have the staff set goals so that they know together, you and the staff set goals together. And then when you evaluate that or they don't follow through on their expectation, they know they set the goal, and then it's not so high stress, it's not so high emotion, right? Because you guys set the goal together.
Right. Excellent. Okay, excellent recommendations. Let me add two things to that. One, we have a mentor in the Crown Council from years ago. His name's Larry Wilson. And Larry Wilson is one of the most prolific corporate trainers in American history. And one of his philosophies that we have talked about for years that highlights what you just talked about here is he says that every great team needs a camping experience every 90 days. Yeah. That doesn't mean they need to go camping. It means they need a camping-like experience. In other words, a bonding experience where they have the opportunity to do something outside the confines of patient care or regular business, which is exactly what you said. Quarterly one-on-ones, regular team meetings, we recommend weekly, morning opportunity meetings, of course. And then one of the biggest takeaways I think that your research has highlighted that everybody can learn from is this whole idea of over communicating and being crystal clear about expectations.
Yeah.
That you can't, and that's not, expectations aren't a demand. They are clearly communicating of when we're in this situation, this is optimal. This is what I like to have happen for the benefit of the patient, the team, the whole deal. One of the things I shared with you when we were together at the recent Dental Digital Marketing Conference is the whole idea that we have promoted in the Crown Council for years of a culture guide, which is written behavioral expectations of the entire team. So that's a form of communicating what your expectations are.
I
And
love it. Yeah.
things
That's
as
such a
simple
good idea.
as, when you're early, you're on time. That, you don't show up at 8:05 when we're having an 8 o'clock meeting. Simple things like that. So being crystal clear about expectations. So and I can hear the voices of some that say, well, gee, doesn't that won't I be accused of micromanaging? As a hygienist, what would you say to that?
To feel micromanaged.
In any of your research, did you ever hear a hygienist or a team member say it's too much? Expectations of the dentist are way too much.
No, it was the main thing was I don't know what I'm supposed to be doing, because I go in and do one thing and then he says another or she says another, and it's I never once heard too much expectations was a bad thing. Yeah. And I don't think it's being micromanaged. I think if everyone knows if everybody knows the rules, then they're free to play, so it makes it a conflict-free zone, right?
So I'm gonna suggest, and you tell me if this is appropriate. I am going to suggest an action when it comes to avoidance.
Yeah, go for it.
And action here is transparency and vulnerability, which is to say, when a dentist feels that twinge of being uncomfortable and not wanting to address something, is to admit it.
Yes.
And say, I am feeling very uncomfortable about having to address something that's on my mind because I'm feeling some tension. I don't want to feel the tension, and I realize it's a potential conflict. So I don't want to talk about this, and I know we need to talk about it.
Yeah.
Good?
Yes. Vulnerability is huge. Yep. And I love the verbiage and language you used.
Good. Your research is great. You're on to
Thank you.
Something. What appealed to me about this so much is we have for decades talked about what we call approval addiction. And you have a much more sophisticated title for it, which is communication accommodation theory.
Yeah.
But basically, we all want to be liked.
Yeah.
And, it starts in the everyday teamwork and everyday communication that we have with each other as we work together. Nobody likes conflict. And you've identified it very clearly. You have reinforced the fact that it's alive and well. And not only with in the team, but also it impacts patient care.
Yeah. I mean, I noticed definitely between like nurses and doctors in the research that research has expanded fully to patient care and what this communication accommodation theory does in patient care. It's huge. The patients can tell when there's conflict between you.
Not a secret.
What?
It's not a secret.
No, it's not a secret. No.
Patients can sense it.
Yep.
All right. So if there are those that would love to read the entire research findings, is that possible?
It's not published, but if you love it that much, email me and I would love to email it back to you.
Perfect. All right. Give everybody your email address.
Yep. It's the social provider at gmail.com. Yep.
The social provider at gmail.com. Very good. And you can request. How long is it, by the way? How many pages?
Oh, it's 19. It's a micro thesis. Yeah.
Cool.
Yeah.
Nice, but an easy read with.
If somebody wants to take it and continue on, please email me. I love that. Yep.
Next body research. Part of what came out of this is what would be the next piece of research that would be done in each area.
Yeah. I would love to read more. I hope somebody else takes it on.
You got you have reinforced some things that I think, if it's news to anybody listening, I think we've all secretly suspected that's the case, and you have just proven that it is widespread. in just about every dental practice. So thanks for raising
Hey,
awareness, and appreciate the recommendations here. If there's a takeaway from Katie's research, is you can't over communicate, and communicating expectations is the name of the game. Everybody's frustrated with unmet expectations, so you got to get them out there and repeat them over and over again. So, Katie, we appreciate you being the resident educator, not only in your practice, but as a Crown Council Mentor of the Month with us. And thank you for sharing your research.
thank you for having me. Appreciate it.
Thanks so much.
Thanks.